welcome to the deep dive. Today we're tackling chronic myeloid leukemia, or CML.
Right.
Think of this as your streamlined guide, sort of, to understanding the key bits of this condition.
Exactly. Hitting the highlights.
We've got some detailed revision notes here, and our mission really is to pull out the core knowledge you need, make it stick,
Let's do it.
Okay, let's jump right in. What exactly defines CML? What is it at its core?
Okay, so at its heart, CML is a cancer of the blood and bone marrow. It's classified as a myeloproliferative disorder.
Myeloproliferative.
Yeah, meaning it starts out in the hematopoietic stem cells inside the bone marrow. These are the kind of foundational cells that make all your blood cells.
Got it. The source.
And a really crucial feature, like the hallmark, is the Philadelphia chromosome. You'll see it called the FIX chromosome.
FIX chromosome, okay.
It's there in over 90% of CML cases.
The Philadelphia chromosome, that sounds pretty central then. What's the story there? What is it?
It involves a specific genetic swap, a translocation between chromosome 9 and chromosome 22.
Ah, the T920.
That's the one, T922. This swap creates a new sort of fused gene called BCR-ABL.
BCR-ABL.
And this gene makes a protein, a tyrosine kinase enzyme, that's basically stuck in the on position. It's constantly active.
Ah, so that's the driver.
That's the driver for CML development, yeah.
So this always-on protein is key. And the notes mention stages. How does CML progress?
Right. CML typically goes through 3 phases. First is the chronic phase. Often people don't have many symptoms here, maybe none.
Okay.
Then it can move to an accelerated phase. This is marked by more immature blood cells, blast cells, and also more basophils, another white cell type.
Right, things are speeding up.
Exactly. And the final stage, the most advanced, is the blast crisis. That's acute, aggressive. It looks a lot like an acute leukemia at that point.
Okay, that gives a clear picture of the progression. What sort of symptoms might someone actually experience with CML?
Well, common ones can be fatigue, like real tiredness that doesn't go away, unintentional weight loss, night sweats, and sometimes an enlarged splenomegaly, which might feel like fullness in the belly.
And how do doctors figure out it's CML? What tests?
Several key things. Primarily blood tests, looking at all the different cell counts.
Okay.
Bone marrow tests, too, to get a direct look at the marrow. And crucially, genetic testing to find that Philadelphia chromosome, or the BCR-ABL gene.
Right, the genetic signature.
Exactly. But the good news, really, is that treatment has come a long way.
That's definitely good to hear. What are the main treatment strategies, then?
The massive breakthrough was the development of tyrosine kinase inhibitors, TKIs.
TKIs.
These drugs specifically target that overactive BCR-ABL protein we talked about.
So they hit the underlying problem.
Precisely. In some cases, an allogeneic hematopoietic stem cell transplant, allo-HSCT, might be an option, but TKIs are really the mainstay now.
Okay.
And what's amazing is how these targeted drugs have just transformed the outlook. Patients can often live a near normal life with treatment and monitoring.
That's huge. A really positive shift.
It really is.
Okay, so we've got a handle on what CML is. Now let's explore its origins, the etiology. What do we know about what causes it?
Well, this is where it gets a bit murky. The exact cause, in most cases, isn't known. It's hard to pin down. We don't see clear links to heredity. Like, it doesn't usually run directly in families. Yeah. And it's not strongly tied to specific places or ethnicities or, socioeconomic factors.
Interesting that it's not easily linked like that.
Yeah. But there is evidence suggesting a higher risk after exposure to high doses of radiation.
Ah, radiation.
Yeah. A famous example is the increased incidence seen in survivors of the atomic bombs in Japan.
Wow.
But here's the thing. While we don't know the initial trigger for most people, that Philadelphia chromosome, the T922 translocation, is absolutely central once it happens.
A genetic error again. It keeps coming up.
Exactly. Like we said, it creates the BCR-ABL fusion gene. And the protein from that gene, the tyrosine kinase, is what drives the abnormal cell growth in CML. So finding BCR-ABL isn't just a feature, it's a critical diagnostic marker. And crucially, it's the target for those TKI drugs.
Which explains why they work so well.
Precisely. It's a direct link between the cause, the molecular mechanism, and the treatment.
That connection is really clear. Okay, so who might be at higher risk? What are the risk factors we know about?
There are several factors linked to increased risk. Age is a big one. The chance of getting CML goes up as you get older.
Makes sense.
Gender plays a small part, too. It's slightly more common in males.
Okay. And any genetic links, even if it's not usually inherited directly.
Well, while CML itself isn't typically inherited, maybe having a family history of certain other blood cancers or some rare inherited genetic mutations might slightly increase the risk.
Got it.
And we mentioned high-dose radiation exposure already. That's a known factor. Also, having had previous cancer treatment with certain types of chemo or radiation can increase the risk down the line.
Right, iatrogenic causes.
Yes. And there are a couple more. Smoking has been linked to a higher risk.
Smoking, too. Interesting.
Yep. And some environmental things like exposure to certain toxins, maybe in the workplace, are considered potential risks. But viral infections, not really associated with CML.
Okay, so a mix of things. Is there a way to remember these?
Yeah, you could use the acronym AGGRIP. It helps pull them together.
AGGRIP. Okay, break it down.
A for age, G for gender, another G for genetics, thinking, family history, or those rare mutations, R for radiation, I for iatrogenic, meaning prior treatment, and P for pollutants, or potentially smoking fits there too.
AGGRP. Age, gender, genetics, radiation, iatrogenic, pollutant, smoking is really handy.
Hope so.
Okay, so we've got the definition, causes, risk factors. Now, let's get into the nuts and bolts of what's actually going wrong inside the body, the pathophysiology.
Right. So the whole process kicks off with that key genetic event, the Philadelphia chromosome from the T922 translocation. This creates the abnormal BCR-ABL1 fusion gene, which, as we said, makes a tyrosine kinase enzyme that's just constantly on. It's constitutively active.
Like a faulty switch stuck on.
Exactly. And this constant on signal tells myeloid cells in the bone marrow to just grow and divide uncontrollably.
Myeloid cells specifically.
Yes. CML mainly affects the granulocyte line. So neutrophils, eosinophils, basophils, you get this massive overproduction of these white blood cells.
Okay.
And lots of them are immature cells, the blasts. They start building up in the bone marrow and then spill out into the blood.
So the bone marrow just gets packed with these abnormal cells.
Totally. It gets overcrowded. And this crowds out the normal cells, trying to make other important things like red blood cells and platelets.
Ah, and that leads to problems.
Yes, that's why you see symptoms like fatigue from anemia, not enough red cells, and maybe more infections, because the functional white cells might be low or not working properly. It's like a factory.
Yeah.
Imagine a factory where one machine goes haywire and starts churning out faulty widgets like crazy. It uses up all the space, all the power, all the raw materials, so the other machines making useful stuff can't operate.
That factory analogy really clicks. Okay. Now, CML sounds quite specific, but are there other conditions that might look similar initially? What about differential diagnoses?
That's a really important question for doctors. Yes, there are other conditions, especially other myeloproliferative neoplasms that can share features.
Yes.
Key ones include polycythemia vera, that's mainly too many red blood cells, essential thrombocythemia, which is too many platelets, myelofibrosis, where a bone marrow gets scarred, and sometimes a leukemoid reaction, which is a really high white count, but usually it's a reaction to something else, like a severe infection, not cancer itself.
So similar blood results on the surface, maybe.
Could be, yeah. High white count, maybe anemia. That's why you need the full workup, the bone marrow test, the genetic testing for BCR-ABL. Those are crucial to nail the diagnosis and tell CML apart from these other things.
Makes perfect sense. Need that specific evidence. Okay, how common is CML? Let's touch on the epidemiology.
Right. So the annual incidence, the number of new cases each year, is around 4.2 per 100,000 people.
Okay, not super common, but not vanishingly rare either.
Exactly. And if you look at all leukemias in adults, CML makes up about 15% of them.
15%.
Now, here's an interesting point about age. It's pretty rare in children. Only about 5% of childhood leukemias are CML.
Only 5%. Wow.
Yeah. The median age when people are diagnosed is actually around 72 years old.
72. So it's much more common later in life.
Definitely. Quite a contrast between kids and older adults.
That age distribution is really striking. Okay, we've laid a lot of groundwork. Now let's picture the patient walking in. What might they actually be experiencing? The clinical presentation, symptoms, and signs.
Okay. So symptom-wise, we've mentioned some already. That persistent fatigue, night sweats, losing weight without trying. Some people feel full quickly when eating or just generally feel bloated or uncomfortable in their abdomen, and sometimes sharp pain in the upper left side of the belly.
What causes that pain?
That can be from the spleen getting so enlarged it causes discomfort, or sometimes even a splenic infarct, where a bit of the spleen tissue dies due to lack of blood supply.
Ouch. Okay. And what might a doctor pick up on examination?
The most common sign by far is that enlarged spleen, splenomegaly. You can often feel it below the ribs.
Right.
And enlarged liver, hepatomegaly, can happen too. Sometimes enlarged lymph nodes, though maybe less common than in other leukemias.
Okay.
If someone's quite anemic, you might see signs of hyperdynamic circulation, like a fast bounding pulse. Easy bruising is possible due to platelet issues, maybe a fever.
Right.
And interestingly, gout can occur. Remember that factory analogy? All that cell production and breakdown releases purines, which can turn into uric acid and cause gout.
Ah, connects back to the pathophysiology.
Exactly. And in less common situations, if the white blood cell count gets extremely high, you can get something called hyperviscosity syndrome.
Hyperviscosity.
Yeah.
Thick blood.
Yeah, essentially. The blood gets too thick, and that can cause serious problems like blurry vision, priapism, which is a persistent, painful erection strokes, confusion.
Wow, those sound serious.
They are, but thankfully less common. It's really important to remember, though, that most people, like 85–90%, are diagnosed in that initial chronic phase.
Right.
And some of those might not have any symptoms at all. It might just get picked up on a routine blood test. So it varies quite a bit.
That variability really highlights why those diagnostic tests are so essential. So let's walk through those investigations again. How is CML actually pinned down and then tracked?
Okay, so when CML is suspected, the first stop is usually the full blood count, the FBC.
What does that typically show?
Often a high white blood cell count leukocytosis. And importantly, you see a whole spectrum of granulocytes, from immature blasts to mature neutrophils, plus often increased eosinophils and basophils.
Like a whole factory line spilling out.
Kind of, yeah. Platelets might be high, low, or normal. And there's often that normochromic, normocytic anemia, meaning red cells look normal, just fewer of them.
Okay. And looking at the blood film itself.
The peripheral blood smear is key. Under the microscope, you see that same range of maturing cells. It almost looks like a bone marrow sample itself, which is quite characteristic.
Ah, okay. What about blood chemistry?
Routine things like urea and electrolytes, UNEs, are usually normal, but LDH, lactate dehydrogenase, is often high. That's a marker of cell turnover. And serum urate might be elevated, tying back to that gout risk.
Got it. So blood tests give strong clues. Then the bone marrow.
Absolutely essential. Bone marrow aspiration and biopsy. This confirms the diagnosis.
What do you see there?
You can quantify the percentage of blasts and basophils important for staging. You assess if there's any fibrosis or scarring in the marrow. And critically, you get material for the genetic tests.
For the Philadelphia chromosome.
Exactly. Cytogenetics looks for the FH chromosome, directly finds it in about 90% of cases. And then more sensitive tests like FAH or PCR look for the BCR-ABL gene or its RNA message. These can pick it up even if the chromosome looks normal sometimes.
Very thorough. And once treatment starts, how do you monitor a response?
Monitoring is vital. We track the response on different levels. Cytogenetic response means checking if the FH chromosome is disappearing using karyotyping or FISH on marrow samples.
Okay.
Then there's molecular response, which is even more sensitive. We use PCR on blood samples to measure the amount of BCR-ABL RNA. The goal is to get that level very low or undetectable.
Measuring the actual activity of the faulty gene.
Precisely. And sometimes, especially if treatment seems less effective, we do BCR-ABL mutation analysis. This looks for specific changes in the gene that might make it resistant to certain TKI drugs.
Ah, to guide treatment changes.
Exactly. The timing of all this monitoring varies, but it's a regular part of CML care.
Sounds like a really well-defined process. Okay, let's shift to the crucial part, managing CML. We've heard about the impact of targeted therapies. Tell us more about treatment approaches.
Right. The treatment landscape for CML has just been utterly changed by TKIs. The main goals are achieving different levels of remission.
Levels.
Yeah. Hematologic remission means the blood counts are normal, spleen isn't enlarged, basically the obvious signs are gone.
Okay.
Cytogenetic remission is deeper. The Philadelphia chromosome is gone from the bone marrow cells we test.
Right.
And the deepest level is molecular remission. That means the BCR-ABL RNA is undetectable or at a very, very low level using that sensitive PCR test. That's often the ultimate goal.
So hitting it at the blood, chromosome, and molecular level. And TKIs are the main way to do that.
Absolutely. Imatinib was the first big one. It specifically blocks that BCR-ABL tyrosine kinase. It was revolutionary in getting patients into remission.
The original game changer.
Definitely. Then came the second and third generation TKIs like nilotinib and dasatinib. These were developed partly to overcome resistance that could develop to imatinib.
Ah, tackling resistance.
Yes. And they might work against certain mutations in the BCR-ABL gene that imatinib doesn't hit as well. Research is always ongoing, looking for ways around resistance, maybe using combinations of drugs, too.
Makes sense. What about official guidelines, like from NICE in the UK? What do they suggest?
Generally, for newly diagnosed adults in the chronic phase, standard dose imatinib is often the first recommendation.
Okay, start with imatinib.
But nilotinib and dasatinib are also options as first-line treatment in some situations. If someone becomes resistant to standard dose imatinib, the guidelines usually recommend switching to nelatinib or dasatinib, rather than just increasing the imatinib dose.
Okay, clear alternatives if needed. Any newer drugs coming through?
Yes, things are still evolving. There's asciminib, which is another TKI, approved for patients who've already tried 2 or more TKIs and don't have a specific resistance mutation called T315I.
Another tool in the toolbox.
Exactly, and there's ongoing research into other pathways like IRAK14 inhibitors, which might help in imatinib-resistant cases, maybe used alongside TKIs. Still early days for some of those, though.
Interesting. And what about stem cell transplants? You mentioned them earlier. Still used?
Yes, allogeneic stem cell transplant still has a role, but it's used much less now thanks to TKIs. It's mainly considered for patients who are resistant to multiple TKIs or if the disease progresses to the accelerated or blast phases.
It's more of a backup option now.
Kind of, yeah. The decision is complex, depends on the CML phase, the patient's overall health, age, what treatments they've had, their specific CML genetics. But TKIs are so effective for most people in the chronic phase.
It really is amazing how targeted therapy has shifted things. So with all this, what's the long-term picture? The prognosis for CML patients today?
It's dramatically better, truly. Before TKIs, the outlook was pretty grim. Now, with TKI treatment started early, the 5-year survival rates are over 90%.
Over 90%. That's incredible compared to before.
It is. Compare that to maybe 33% back in the day. And 10-year survival rates are also way up around 84% now, compared to maybe 11% pre-TKIs.
Huge difference.
Massive. And we see a large majority, like 70–90%, achieve that complete cytogenetic response, the disappearance of the FISH chromosome.
Wow.
So for most people diagnosed in the chronic phase today, the expectation is that they can live a normal or very close to normal lifespan with ongoing treatment and careful monitoring.
That's such a hopeful message.
It really is. And that mutation analysis helps too. Identifying resistance early means treatment can be adjusted quickly to keep things under control.
So CML has really shifted from being, often fatal fairly quickly to being a manageable long-term condition for many.
Precisely. It's one of the poster children, really, for how understanding the molecular basis of a cancer can lead to incredibly effective targeted therapies.
Well, this has been a fantastic deep dive into chronic myeloid leukemia. We've really covered the ground definition, causes, risks, pathophysiology, differential, how common it is, symptoms, tests, management, and that much improved prognosis.
Covered a lot.
I think the key takeaways for you listening have to be that Philadelphia chromosome, T922. The BCR-ABL gene.
The core genetic lesion.
And the transformative effect of those tyrosine kinase inhibitors, the TKIs.
Absolutely. And maybe the final thought is just that journey from a really feared diagnosis to something that, while still serious and needing lifelong management, is often compatible with a long and full life. That's down to scientific progress.
A really powerful example of medical advancement. For those of you wanting to cement this knowledge or explore further, definitely check out PassThemCellRay.com.
Great resource.
And also FreeMCellRay.com for more revision tools. They're both excellent for digging deeper. Thanks so much for joining us for this deep dive today.
Thank you. It was great talking it through.